Good afternoon and welcome. Yes, I'm delighted to introduce the next session, which is Data for Society, a Global Health Connector Partnership Perspective. And it's my pleasure to introduce the moderator, who is Brian O'Connor, the chair of the ECHAlliance, the founder indeed of the ECHAlliance, international businessman, and now the founder of the Global Health Connector. Brian, over to you.
That's the nicest thing Bledden has ever said about me, is the first thing I would say. So thank you, Bledden. First of all, welcome to everyone. We know we've a lot of participants listening in today from a very brilliant morning session, but primarily about Europe this morning. This journey for the next hour or so is to try to give a perspective from around the world, literally around the world. So I want to talk to you first and say the Global Health Connector really started, I suppose, in March or so of 2020, when I suddenly realized, first of all, I wasn't going to be able to travel every week as I used to be able to travel. And I suddenly realized I was going to be sitting here and thinking, well, that's going to be boring. What can I do? So I contacted friends like Anne and Amit and Raj and others around the world and said, why don't we convene a meeting and see, we now have a global pandemic. It needs a global response. In our own, perhaps small way, what can we do to help different countries and each other in that? So I'm glad to say we convened a meeting. The people you see here today are all council members of the Global Health Connector. And I'm glad to say that since then, we've had lots of interactions, lots of events, lots of assisting each other and collaborating. And I think my feeling is we've just begun. So today, we're going to get views from the US, from Africa and from India. And really what I'd like to do is start off by introducing Anne Mond Johnson from one of our members in the Global Health Connector, the American Telemedicine Association. And I'd like Anne to give us some sort of perspective on what's happening in the States. We read all the headlines, but you live there in DC. So give us your view, if you could, for the next 5 minutes or 6 minutes or so. Please.
Absolutely. And it's great to be with all of you and fun to be with you and Amit and Raj. I really have valued the Global Health Connector. From the US perspective, a little bit of background on the American Telemedicine Association. We represent over 400 organizations that are all dedicated to the vision that people should get care where and when they need it. And then when they do, they know it's safe, effective, and appropriate while enabling clinicians to do more good for more people. Our members include delivery systems, multi-hospital systems, as they're called here, as well as provider groups, payers. These are private insurance companies. And then we have a range of solution providers. These include companies like Teladoc Health and Amwell, which at least Teladoc Health I know operates in Europe. And then organizations that are more asynchronous in their approach, like Babylon Health, which came out of the UK. And then a number of organizations that are focused on remote monitoring, because that's also a very important component of telehealth. And then organizations that are focused on infrastructure and technologies such as Philips, HP, Intel, Microsoft, AWS, and so forth. So it's a very diverse, eclectic group of members. And I would say the view from the US is, first of all, from the policy perspective, one thing that was really interesting about the pandemic is that generally there was a lack of understanding of what could be done from a federal perspective and what could be done amongst the 50 states. And so there was a little bit of confusion on that. And now we're sorting through a lot of the changes that we hope become permanent. From the federal perspective, there was really this issue of geographic site and originating site restrictions. In other words, pre-pandemic, pre-public health emergency, you could only provide telehealth services and have them reimbursed under very strict limitations. And with the public health emergency, that all went by the wayside. And we're working hard at the federal level to make sure that that waiver or that relaxation becomes permanent. From the states, as you can imagine, there are 50 states and there are 50 viewpoints on how different things should be done. And the states really have authority around licensure around standards of practice, around scope of practice, and then reimbursement among private insurance and Medicaid. So they have a different purview and a different focus, and you can't hope that change in one state will necessarily impact all states. And so there it's much more ground game and going capital by capital and addressing the issues there. I think the second thing that we're contending with is that we know as a nation, and certainly following the murder of George Floyd, there's been a lot more conversation about the inequity that was present in the US and very much reflected in what was happening in the healthcare system. There was inadequate access, inadequate connectivity, and really so profound that the roots of that and the factors associated with that, they've been around for a long time, but we're finally having conversations around this. So I would say that there's a number of different efforts on how we can use, at least within our group, how we can use telehealth to eliminate disparities that have existed for far too long. And then the third thing that we're dealing with here in the US is how do you operationalize hybrid? So as much as I personally may be enchanted with telehealth, I know that it's not for everyone, it's not for everything. And so what we have to do is really be very thoughtful about the use cases associated with it. So as you've all seen from the data, pre-pandemic, less than 1% of Medicare services were done or visits were done virtually or with telehealth. And it went up unbelievably with the pandemic, with the height of the pandemic in March and April, and then it's since dropped down, but it's still higher than it was before. And we think we have really an opportunity there to make sure that we work with the broader community to address all that and really define what are the use cases and what does that look like in terms of operationalizing virtual care, again, to make it safe, effective, and reliable. So that's, I think, I would also say that we're headed into winter. So there's, while mask mandates are being lifted in many communities, again, that's state by state and even community by community, we're also seeing an increase in numbers. So we're putting our seatbelts back on and bracing ourselves.
Thanks very much indeed, Anne. That was a great introduction, a great overview. We'll now switch then to Africa and introduce you to Amit, who many of you already know. And Amit, could you take the same line as Anne and just give us that introduction, please? You there, Amit?
Yeah, so
oh, sorry.
My name is Amit. Yeah. Yeah, you want an introduction just on what's happening in Africa and what's
maybe introduce yourself as well in the African Healthcare Federation, etc. Just to give people a background check.
So thanks, Anne, and it's good to be here with Raj and Brian and the team members from ECHA. My name is Amit Thakker. I'm in Nairobi, and I'm the president of Africa Healthcare Federation, which is an umbrella body of 27 countries in Africa. And as the voice of the private sector, we work very closely with the members in country. So our members are based in country, multinationals, locals, SMEs. We also bring smaller umbrella bodies together in the country, such as Doctors Association, technicians, pharmacists, professional associations. So over the last 15 to 18 years, we've been working on organizing the largely fragmented private sector. In many countries, they work more like silos, that hospital groups work on their own, medical devices work on their own, digital companies work on their own, and you'll see these clusters spread globally. We thought that a new overarching umbrella body will create the impetus. We didn't know the impact, but the impact is significant. And this has been proven in almost 27 countries. So it's a unique model. And after about 15 countries formed a federation in 2016, the journey from 2002, we decided to form the Africa Healthcare Federation, which would be an overarching organization that will work with the African agencies like Africa Union, Africa CDC, and others. What have we witnessed as private sector on the healthcare side on the continent? And what do we think is going to happen after the pandemic? I haven't seen such a paradigm shift for digital health like I have seen now. So, like supply chain was exposed, so was the digital regulatory framework. It was extremely weak, and within very short time, many countries had to quickly think of licensing digital providers, approve maybe digital solutions. In a country like Kenya, where I am, we had 0 telemedicine licenses. Now we've issued 73. And we are a bit concerned because when we do this very rapidly, obviously there will be gaps. So beyond the pandemic, there are several points that I want to highlight that are going to make digital health a central cross-cutting enabler. The first one, I believe, is we have the youngest population globally. With an average age of 19, the youthful population of 1.3 billion are going to take up digital health almost like a different level of speed than the generation before them. The generation before them who are not used to seeking healthcare, either through apps or by telemedicine, the youth will take it and they will be the operators of these digital solutions. The second thing is all global partners such as USAID, WHO. When I see now work for strengthening health systems in Africa, they have a component for digital health. Right now, I'm working on health system strengthening and changing local manufacturing. One of the cross-cutting agenda is what are the digital health innovations? So it looks like all experts in strengthening, either at the Ministry of Health or in private sector, are trying to bring what's the digital innovation that's going to change manufacturing, health service delivery, health research, and so on and so forth. That's the second point I've noticed. The third point I've noticed is during a crisis, the amount of innovations that take place is sometimes incredible. I've been so impressed by the countries in Africa that have used digital solutions to curb the pandemic. It's incredible. People say that it may be the vaccinations or exposure to BCG. If you compare us to all the other countries around the world, there were certain things that these countries did. Maybe the virus came later, but the apps, I have used an application to manage how the vaccines will be given, delivered, and eventually I got a certificate with reminders like SMS. And all these are homegrown solutions. Quite simple. Not only simple, but it's showcasing why Africa can show the world what could be very, very nimble and cost effective and can be used in healthcare. So I saw these. One is called Mchanjo system, homegrown by young Kenyans. Quite classic. I've looked even at the Indian system, COVID, and I've seen what they were able to do. And I compared the features. And, I think that these crises bring out the best of the best, sometimes within your own countries. And it's really great to celebrate them. And they have saved lives and livelihoods because of the innovation. The fourth point that I want to mention is when the supply chain shut down, we had to start thinking about our own systems like ventilators, not to mention PPEs and others. But I think the whole digital prowess in monitoring medical devices, medical systems to strengthen this, whether it's even trying to follow up critical cases, came up really, really quickly. Again, these were innovations that are homegrown. So, Brian, what I'm saying at the end is, I think this has been the biggest wake-up call. I don't think that I witnessed a bigger wake-up call for adopting digital systems like the one we did. So when it comes to Global Health Connector, I believe it's very centrally placed to share best practices, to share ideas, and learn from each other on what works, borrow from different continents and different countries, and scale up the progress that we want to see in our regions. I'm really delighted that I can share this platform, connect people, multinationals, and I encourage you to carry on with this system with many more people involved. Thanks.
Thanks very much indeed, Amit. That was great. Moving straight on then, journeying across to India. Raj, do you want to pick up on that and give us your thoughts?
Thanks, Brian, and good morning, Anne, and I think it's good afternoon probably for Amit, but whatever it is, I think I am really enjoying what brand you have created. In fact, this was a umbrella organization we probably lack to get like-minded people and getting at a frequency that we need to. I totally agree with what Anne and Amit said, that COVID brought us too many opportunities and we at least fall short of time now. So, we were falling short because of travels and not because of traveling. India is also the same, when 25 years ago, when we started looking at technology-driven care, people said, there's no future for it, don't unnecessarily bang your head. It's a clinician's game, let them do it, and they know how to do it. I think they were talking of eminence-based medicine, and we were talking of evidence-based medicine for digital health. But they believed, that what they have been practicing for decades is going to work. But India is like, you need to understand the country in perspective. What small percentage is a big number. 1% of population is 13.9 million. You're talking of a couple of countries. It's huge. And it becomes more complex because like US or like any other, health is a state subject. So 36 states and union territories are de facto the kings of their fiefdoms called health. And the central government has actually no role in real sense if you talk constitution wise. But the challenges remain. We are still a lower middle income country. And any lower middle income country has to ensure that health and education remains a social good. Now that brings the challenge. Technology always remained a holy grail, but typically the bureaucrats at the helm never realize it. Now, we've been pushing. In 2014, I wrote the policies for the incoming government. 2017, I did the same with National Health Policy, clearly articulating what digital health will do, specifying all the words, Internet of Things, wearables, cloud. But still, I must confess that with all the hard work, efforts, and I think you asked one question, that what does Global Health Connector do? So if you have to ever thank India for what it did and who did, please thank organizations like yours. I must say, as a policymaker, I served as an advisor to the health minister from tabling the resolution in WHO, and the first one on digital health came from India, to clearly articulating the health policy came from organizations like ATA, HIMSS. I would clearly say ECHA. We learned. I was confident. If I put in the policy, we will deliver it. As Amit said, we had homegrown companies, same for India. But people were shy putting in because they didn't have the exposure. I had courtesy friends like you. Being on international forums, you could see solutions. You tell me one problem, they had 100 solutions. So I was sure when I was putting in cloud and variables, people were telling me, Rajendra, why are you articulating this? Just write ICT. I said, I'm sorry. If I write ICT, you will interpret in your own manner, forget implementation. So look at from that situation to where we are today. I think for me, the success lies in implementation. It's not about putting policies in place. So, and as a policymaker, I think the theme is good in terms of data. So luckily for digital health, everything you and I do is data. Even when we are talking, it's the data packets that are getting transmitted. That's digital health. It's all about data. And when I look at, I see clear roles, and I will tell you what India delivered on that. So the first role is on the policy. I'm a firm believer of data. I mean, I think it goes without saying that besides God, we believe in data. And I do actually read all my books, they will be packed with data. So whenever I wrote policies, I always backed them by data, so no one challenged them. So it got approved. And for me, it has come handy to make a case for digital health. Second is in terms of programs. I sometimes believe which countries can afford to do healthcare without epidemiology. Again, it's data. And third, what we call as intelligent data is AI. Look at the classic case of COVID. All the repurposed drugs came thanks to AI. We saw AI in action. The closest it could get, for us to, get benefit out of it. And I think all this has led to culmination of launching the world's biggest digital health mission in India, which was launched on 27 September. And I was addressing our ministry on the third year of our Ayushman Bharat scheme, which is again the world's largest insurance scheme for 550 million. So we launched this Ayushman Bharat digital mission, which remains the world's biggest digital mission. And I think, as Amit mentioned about COVID app, so it is again, when we got stuck into this, we had to create safe spot, we had to create hotspots for COVID. And for me, all these policies finally delivered the numbers that I want to look at and say, look, we did a good job. So numbers tell me that we did more than 207 million downloads for that COVID app. I think probably could be one of the most downloaded apps in digital health. The best number I would always remember is more than 1,000 million COVID vaccinations. I mean, for some people, it will be like unimaginable. For us, we are still almost getting halfway close in terms of multiple doses that we have to give. And this is done booking the appointments through the app, getting the certificate. I used to sometimes believe that I'm sure it will not work. Some problem will come up because I travel. And when you're traveling by air, you have to show them the certificate. And very difficult to carry papers every time with you. Luckily, with 1,000 million vaccinations, I have all my data on my mobile on this app. It has never crashed. Hope it will never crash. Look at the hospitalization data for the largest insurance scheme. So we have 22.7 million hospitalizations since we launched 3 years ago. One hospitalization every 3 seconds. That's an amazing number. And when you talk of India, people say, that will digital health succeed? Any country, which is most of these countries in the world, the choice is between no health and digital health. It's a no-brainer. When you don't have doctors and on one side you have a digital doctor, why would you think about deciding or choosing? I mean, absolutely, you got to do digital health, as simple as that. So government took a decision that we had health and wellness centers, which were earlier avatars called the sub centers and primary centers. We said we convert all the 150,000 of these centers into health and wellness centers with the element of telemedicine. So I'm clearly seeing that implementation. I mean, for these numbers, when last April we created eSanjeevani app, it was actually there for close to, I think, more than a decade. I would say more than a decade because I have been in it, but it was lying in a closed box. No one used it. Since it was started using last year, we have 12 million consultations digitally. And this is capable of doing 500,000 consultations, which will not be a big number for India any day. It is 500,000 consultations a day that what we can do. So when I look at all this, I clearly think India made a big leap in terms of institutionalizing digital health. We have, and this is what my biggest legacy and contribution to the country would be. When I was writing the policy and drafting this, I said, I have seen how government system works anywhere in the world. You get a good bureaucrat, he loves the program, he will support it. Someone else comes, he says, no, I think digital health doesn't work. Let's go back to the old ways. So I always believe in creating institutions. Like Brian, you connected the Global Health Connector institution. So when I created that we will have a National Digital Health Authority, the National Health Authority, people said, just create a program. I said, no, because an institution will last. Anyone who steps in the shoes to head the institution will have to deliver the mandate of the institution. And I'm so happy that when you institutionalize something, and that too in mission mode, which we did in digital health mission, we are seeing the results, and they are in millions, and they keep adding up every second. That's the beauty of what we did. I think this is what I see. And when you ask what's the future is what we are talking today. The future is what we are doing today, and that is data. Now, the biggest challenge India still has is, as healthcare will always have, and I think all these people in the frame who in some way are thought leaders in global digital health, is that digital health will actually try to become a monopoly of those big 5 companies, the big tech, like it or not. And so for organizations, wherever I am, and Brian, I'm going to rope you in the UN meeting on 10 December, keep that date blocked. I have strongly encouraged there should be large number of small companies, not small number of large companies. And this is something that we all have to finally agree upon if we want to make healthcare accessible, affordable, and effective. For digital health, it's a mandate. Like Amit has said, that homegrown companies are much better. They also need to be more. Few companies will get acquired, but if you create large number of companies which are small, I think that's where we'll deliver innovations in digital. They will compete, they will become better. I clearly see a whole lot of work to be done. So when Brian, you keep asking, what do you feel about Health Connector? I think it's a wonderful platform. How will I get to meet Anne or Amit or others on this? She would probably not give me time when I travel to US. Amit would say I'm too busy, but at least on Health Connector, I'll get a good 1 hour slot, and that too, as frequently as you call all of us. So I think this always helps us to think through. It is not that we all come and repeat every time what we have to say the last time we said, but it also encourages us to think beyond. We learn from each other. And I think this is how digital health has evolved. Today, a lot of people may, give credit to COVID. COVID actually did only one thing. Whatever we had as a knowledge consortium, whatever we were ready with, we just implemented it. Just imagine if these things would not have been happening, if ATA would not have been doing those big summits, if, HIMSS would not have been doing, if you would not have been doing, we would have started searching, what would you get then? Well, I have seen what has been happening. So it was easy for the country to be ready to say, hey, look, there can be an app that can deliver vaccination. So I think digital platforms actually became the success story for digital health, and we owe it to them. Thanks, Brian.
Thanks very much indeed. If I may, I'll just come to you, Amit, because I know you've got to go shortly, but maybe you could just, because there's a lot of similarities in what all three have said. You've had the difficulties having national governments. In your case, Amit, it wasn't even the national government. You had to bring together 27 actual countries. In Anne's case, you had the national or the federal level, and then the states. And in your case, you had all the states within India. So that itself was quite an intricate and complex issue. But given we've got you just for a few minutes, Amit, I just wanted to see, in terms of your reaction, do you see the companies you talked about in Africa? As you know, I'm a great believer in Africa, and I believe very strongly that you should be exporting throughout the world. And I think that's beginning to happen. We certainly want to help you do that. What do you see happening next? I mean, yes, the COVID has accelerated things. Just give us your couple of minutes, if you could, before you have to leave, please.
I'm keen to have a robust digital health community Africa. Everybody's talking about it. So first things first. We have a lot going on, but I think we need to get our ducks in a row. And I think there is a call out for the Digital Health Com Africa. Now, the heads of state have created something called Smart Africa, Brian. I don't know whether you've seen it. And President Kagame is quite a proponent. I would like your connector to reach out to Smart Africa. And Smart Africa was making it digitally enabled. It's a strong, solid institution with large companies like Google and Microsoft, all of them there. But they're looking for someone who can enrich the health arm. And we were talking to them, and our advocacy forum, which is much wider in health, does not have a specific digital committee or arm. So when I spoke to a few companies, and a very many interested organizations for Africa like yourself, they are thinking of creating that community of digital health in Africa. So I don't know, but I would say that's one thing to do. It would serve as the voice of the Smart Africa Health. And then it will create trade engagements over the next 3 years, which will be intentional and dedicated. There will be a reverse trade mission with some of the countries, and there will be joint ventures and partnerships. And maybe we could have a digital health innovation summit once every year, once every 2 years, and we could fuel up this collaboration of companies like Teladoc and many others that we've seen. Babylon wants to be on board like this. I am thinking that might be a way forward. Over.
As usual, very practical and to the point. I mean, no, because we have to do specifics. As we've all said, implementation is the key here. You can't just talk forever. You've got to actually do. And you've all been doing, as we are in the Alliance and in the Global Health Connector. So that's a great tip. I'll follow up with you on that, on the Smart Africa, because yesterday, just to briefly tell you, I had a conversation offline with people from the WHO, and they were saying that what they lack generally in the world is what they referred to as a delivery mechanism. A delivery mechanism. So yes, they can do the policy papers. Yes, they can do the encouragement. Yes, they can do the stats and the policies and the data. But how do you get onto the ground? How do you get to the grassroots? And that's why they were talking to the Alliance, for example, about using our 70 ecosystems to help them deliver down to the grassroots in different regions and countries. And I'm in discussion at the moment about trying to set up some ecosystems, for example, in the same methodology in the States. So though they all may look in different continents, different things, we think maybe the next stage with the connector is to actually talk about what's on the ground. We all want to implement. We all know people. Why don't we just create similar structures in each country through all of our contacts? They'll all look slightly different, but they're all connected. And I think that's the message that we want to make. So I will follow up, Amit. Thank you very much for that. I know you'll have to duck out, but thank you very much.
Thank you, Raj, and thank you, Anne, as well. I do have to jump off, but I look forward to connecting with you both again. Bye for now.
Thank you. Thanks very much. So, and if I could come to you then, having picked up on Raj and Amit and my comments, would you like to pick up on that and talk about what could we do on I like practicalities, as you know. So what on a practical basis should we all do to implement what we all know needs to be implemented? What happens in the States, for example?
Well, I think there's a couple of comments. One is that it's worth pointing out that there's been a lot of mutual learning. And to your point initially, Brian, this is a global pandemic and it required a global response. So I think there were a lot of commonalities that we can point to. And one is the whole speed of innovation, right? I mean, just things moved so quickly. And learning that, you know, as you were iterating on the fly, realizing in Europe, for example, I think it was your colleagues who talked about, or one of your groups that you pulled together talking about doing new protocols, going back and forth on WhatsApp. They had groups that had formed on WhatsApp to create and confer. So I love that. The other is, you know, to Raj's point about the choice between virtual health and no health, that's a mindset that we have to accept here in the US. We get a little tripped up on reimbursement. We get a little tripped up on, you know, who's going to pay for this. And we have, you know, this incredible focus on brick and mortar that I think is really, it can be very limiting. And I think the other thing that I learned from Amit early on is that there's a whole level of infrastructure investment that they got to leapfrog. I mean, people lived on their phones anyway in Africa, and we didn't have that sensibility or at least that discipline. So I think from the other thing I'll point out is that as we've started going on this journey around disparities and how you can use virtual services to address disparities, it's an issue everywhere. And it's not limited to what's going on in the United States. And how you solve for it, of course, is going to be important and may be very specific to different cultures or different nations. But I think we're all going to have to contend with adequate connectivity, adequate devices, the whole idea of what we call literacy. Part of what Amit was celebrating with these grassroots efforts, and Raj also, is that they were very simple. They had the user in mind. The user experience was right there. And so you didn't have to guess at it. And then we have a lot of bias that we deal with here in the US. And you have your own kind of bias, I'm sure, in India and probably in the 37 countries that Amit's involved with. So I think there's some practical work that can be done around this framework, for example, on how we deal with disparities across the globe, because there's too much of a divide between the haves and the have-nots. And to have it expressed in health, it's economically defeating for any country. So we have to, I would put that out there as one area. Curious what you think, Raj.
And it's always amazing to hear, and it's difficult to speak after you, but I'll have to speak something. Firstly, Brian has set up this great platform, and I see that, whatever we accomplished in the last 2 years is barely anything. Let's accept that. It's a knee-jerk reaction to the enormous challenge we all faced and healthcare in terms of governance, financing, delivery, all three fronts. But to conclude that we got a clear direction would be terribly wrong. Yeah, we do see a straight line, but how long it's going to remain straight, we don't know. I think that's where I look forward to the global health connector to be, and Brian, this is what my suggestion is, that if we can, convene the forums for public consumption should always happen. We get to create more future leaders. That's what we are trying to do through Health Parliament, you and our mentor as well. We should have our informal digital coffee sessions, where we 1 hour sit together and ideate what did we find innovative last month, what are the new things we are looking at, because I think ideas come from discussions, and luckily you are able to connect and get everyone on board. So being the real connector, I think we should do, because I still believe that real challenge lies in continuing with this momentum. How do you take this momentum ahead? I see a lot of excitement, a lot of investment, but I also see that though we call it an ecosystem, but we are not addressing it from an ecosystem perspective. I think next month, I'm going to come back to you. We started drafting the global digital health practice guidelines, and Brian, that whatever I do, you will have to be a part of it. You don't have a choice, and you're always very gracious to come and extend your support. And I would like you to lead that along with what we are doing, because people need to have those practice guidelines. So we started working on it, and these are global. And I also want to say that WHO of late has also, got into that. I have been a part of their global guidelines development group for digital health and the global roster of experts. But what they started now, Brian, is they want to be a one-stop shop for digital health information. I'm co-chairing that group where they want to create this digital health thing, but how WHO works, so I think we need to keep doing our efforts. WHO will keep doing their efforts. They have too much on their plate, though now with the focus with the complete Department of Digital Health, the Department of Human Capacity Building, and wonderful people there at WHO. But I think still, as the global health connector, we have enormous responsibility. A connector does not connect for the sake of connecting. It is about impact. We all need to create impact. And I think that is what we all have been focused around. So maybe let's try to do where all of us grab a coffee and sit and talk. There should not be an agenda, but let us share. Maybe today you have 3 regions, maybe get 5, 6, get country specific. So let's understand, because I think the innovation is going to come from the countries which are struggling. And the struggle is going to increase because you see increase of digital health, but there has been an economic collapse because of COVID.
Yeah.
Please have to shut down. You have seen the $1.8 trillion, the bill that US administration is passing. You can imagine what it takes to support growth now, which means effectively same government grant and funds have to come for digital health. How would they happen? Who would pay for health? So I think The real crisis in trying to figure out the funding mechanisms. At the end of it, that is what I think the world struggled earlier. We couldn't take off. Now that government pushed and cleared the envelope, loosened the guidelines, we were able to do. But more than that, that sustained growth has to come. We should all work together to do it. And I think you have the right people in the room.
Thanks very much indeed. And I'm going to come to you in just a moment because I wanted to ask you about the infrastructure bill. And is there anything in that which might help the whole question of health and telehealth, etc.? But I'll give you that notice. I wanted to bring Bleddyn back in. As you know, Bleddyn is Deputy Chair of the Alliance, but also the Chair of the Digital Health Society, whose conference we're in today. Bleddyn, this morning's session, and indeed all the work you've done over the last year or two, focuses primarily on Europe, though it's starting to expand internationally, naturally. Where is Europe in terms, you talked about the European health data space and various other things, most of which I have to say is probably not known much outside Europe. And maybe you could just give us a quick, if you don't mind, I know I'm throwing this at you, but you're quite capable. Off you go. Tell us where we are in Europe.
So I think that the challenge in Europe is not to be so insular that we only look at Europe. The whole idea of the European Connected Health Alliance expanding beyond Europe was a recognition that no country has a right to monopolize innovation or good ideas. And in terms of frugal innovation, we know that both India and Africa are in some ways leading the way over Europe. So one of the things in the Digital Health Society we've been very cognizant of is the need to look outside of Europe as we look at some of the challenges that either the European health data space or more widely industry and member states and healthcare systems have. So I think that we're very open to reaching out, listening and sharing knowledge. The whole idea that data is a monopoly of one country or one region. We talk about, and this morning we had a couple of comments about data as a societal good, and that the idea that what we need to do is share data or data analysis in order to unlock that societal good that exists there. And I couldn't agree with Raj more. It's then about impact. So it's not about writing papers. It's not about spending time always talking about things. It's actually what impact can we have in terms of improving the quality of services, increasing the health equality, making sure that, if you like, the digital and data do not lead to greater digital exclusion to healthcare services for our citizens and populations. So I think that the Digital Health Society is very keen to be involved in the wider global work of the Global Health Connector around the digital and data agenda. It just makes sense.
Thanks very much, Bleddyn. We've got some questions coming in, one of them directed particularly at you, Anne, but before you answer the question, you don't even know what's happening yet, but perhaps you could just respond to my question on the infrastructure. This is the question of a government pouring whatever it was amount of money into the economy generally. What do you get out of it, or what does this sector get out of it, basically, if anything?
So the aspiration is always on the infrastructure that it has to do with connectivity, and that we want to have funds go to support the ability to have individuals, all Americans, regardless of where they are, have access to digital services. So that, I think, while we haven't called it a social utility or social good completely, I think that there's been a lot there. But again, what I'll point back to is the work that we've been doing that your colleagues actually listen in on the disparities, is that if you think about connectivity, that's almost the tip of the iceberg. You can have great connectivity, but if you don't solve for, at least in the US, we have an issue of data plan. So if you're using all your data plan on services and you can't afford a larger data plan, that's a problem. So it's not even affordability of the service, it's affordability of the data plan. it's the devices, it's the whole issue of literacy, and the fact that, you know, we have this obligation really to make sure that we provide services that are easy for consumers to use. So my point is that while I'm very optimistic about what we might be doing from an infrastructure perspective, it's only the tip of the iceberg, and it doesn't really solve. It's a great step forward, but it doesn't solve point blank everything else. So I'll leave it at that.
And just to pick up on a couple of things, first of all, thank you for the message came in just for yourself, Raj, from one of your Indian colleagues who said, and indeed it was also said by Amit, this idea of having a large number of small companies as opposed to just a small number of large companies. And obviously you need both, but the infrastructure requires a significant number of SMEs and startups and so on. So that's just to confirm that's the view of the panel. There's another question from someone we all know very well indeed, Donna Henderson from Scotland. And she's raised the question of, on a practical basis, what are you going to do next? And one of the things, Anne, you and I have touched on before, is linking up linking our thematic innovation ecosystems, which deal with specific topics cross-border, with your, I think you call them SIGs. And Donna's saying, in the nicest way, so are you going to do that? And you and I are meeting in Washington, I'm glad to say, in a couple of weeks' time, and no doubt that'll be on our agenda. But maybe just touch for the audience on what a SIG is, just to help them, please.
Absolutely. And hello, Donna. I can't see you, but I'm glad you're in the audience. We have within the ATA, which has been around for over 25 years. I've only been with the organization for a few years, but it was started by the clinicians and the researchers, the pioneers really in the industry, and they organized around what we call special interest groups. And these groups did things like create practice guidelines that Raj was talking about. And these, of course, were very important in terms of setting standards for how telehealth might be done across different specialties. Right. Those SIGs have expanded. And the reason why they've expanded is because the industry has changed. And we have a lot more than just synchronous communication now. We have synchronous, asynchronous, and remote monitoring. So we have SIGs that get together on remote monitoring. We have SIGs that get together on different policy issues at the state level as well as at the federal level. We have SIGs that work on topics like decentralized clinical trials, because if you can think about a sector of the industry, the health industry, that would benefit from virtual, it's clinical trials. You reach a much broader audience in a much more expedient fashion. So being client driven, we like to think of ourselves as that if someone has a particular idea for a special interest group, typically we organize a roundtable and see if there's any sort of interest. We make it broadly available to members and non-members, and then from that use that as a way of creating some momentum. So an area that we're working on now is home testing. Again, it's sort of we use the expression Wild West, where there aren't a lot of laws or aren't a lot of standards. And so putting those in place within that special interest group as well. But I was excited to hear Raj talk about the practice guidelines. We're likewise, there's a lot of different groups that are venturing in this area, and we want to be as practical and pragmatic as possible.
Thanks very much indeed. And hopefully that answers Donna's question. And you can be sure, Donna, that because you have talked to me about how much you enjoy being on the ATA SIG, and it's clear to me that I think all of us, each of our organizations, and by the way, there are many more council members other than those on the call today. If each of us look at what we do already, in many cases, we don't need to change very much about what we do, but we need to connect it to other people. So by literally the simple act of talking to each other, and as Bledden said earlier, listening, and then working out, okay, that all sounds great. So what is my question? Are we going to do something about it? And as usual, we will end up doing something about it. So that's on the agenda for Washington for sure, in early December. Bledden, can I just come back to you for a moment? I want to talk about standards interoperability, all the stuff people have talked about for, as far as I can see, for the whole of my lifetime, which is a long time. People go down rabbit holes, as we call it here. They just disappear because some of the nerds, and excuse my expression, but it's true, many people love the idea of standards and worrying about this word and that word, and they're all important. But on the other hand, my question is Europe making any practical steps forward to actually implement some standards which will allow innovation and allow better services to citizens?
So I think if Deepak Kalra was answering that question, he'd be saying that for 20 years he's been talking about standards, and whether it's interoperability or semantic standards, and so clearly in many ways we have struggled for a variety of reasons to get alignment around particular standards, and I think that some countries have seen promoting their own standard as driving economic benefits. And I'm not sure that that has helped patients and citizens and society as a whole. But I think we can be optimistic that the crisis has caused a need for what was described this morning as substantial action now, not continuing to talk about things. So the e-health network and the success of the COVID passport, where standards have had to be agreed, not talked about, but agreed in days and weeks rather than months and years, has shown that with the right incentive, member states, in particular in the European context, have been able to agree and align because it's been a health imperative to do that. And I think picking up on what a number of you have been saying on this panel is that we must not lose this momentum. We must not slide back digitally from the advantages that have been seen. And we must build on that. And if anything, accelerate further in terms of utilizing and agreeing standards. And I think what I'm really interested in is that inside some of our latest roundtable 4, we've started to contemplate, well, how could you take what is the COVID passport and expand it? And so, for example, one of our pharma members is promoting at the moment the idea that the vaccine passport should not just be for COVID. It could easily extend to all types of vaccines. And that makes eminent sense. And we've started to think, well, actually, and then you could take that even further. So you could look at it and say, why can't it be having drug prescribing information on it? And then why couldn't you turn the vaccine passport into a health passport in which you also have summary care records? And when you see the scale of what Raj has been achieving in India in terms of, the 1,000 million vaccination records, the number of downloads, this should be possible. I think we have to be brave and be determined not to be limited in our ambition. And it would be fantastic if we can see an alignment across the global health connector with a number of the countries to try and push this type of initiative.
I just want to take another question from the audience. It's from Alexander Berler, who we know very well. First met him in Athens, I think it was, all those years ago. His question is that the implementation of telehealth, telemedicine across Europe has been really slow. I think I'm hopefully quoting you correctly, Alexander. And that basically he's saying, so has anybody got a cookbook which allows us to accelerate what we're doing in Europe? Because we've been held back in Europe by regulation, by different countries doing different things, and not actually taking the lessons and learning from the mistakes of others, but rather just being isolated and siloed. So, and you seem to be the one that in the States, despite the complexity of the States, and I must admit, I watched the work you have done with the each state in turn, where you're trying to get them. Perhaps you could just touch on that. Maybe it might give Alexander some hope that there is hope, that we might be able to do something. So you've had to deal with complex, in fact, more states than we have member states in Europe. So maybe you just give a few tips to Alexander.
Well, I think one of the interesting things that's happened during the pandemic is that some of the, at least younger companies, earlier stage companies, were not necessarily aware of all the rules and regulations. And so while necessity is the mother of invention, ignorance can sometimes be bliss. And so the idea of moving full scale quickly, I think the trick in getting things adopted very quickly is this whole notion of designing it for the user as opposed to designing it for who you are, right? And that I think has been a pitfall over and over again. So I think we heard from Raj and we heard from Amit, and we're certainly seeing it. You know, we have members like Doximity that have literally thousands and thousands of physicians who are using their app because it's so easy. It's just super, super easy to use. So the other thing I want to point to one of Bleden's comments about the health record is that has been a rallying cry within the US. If you think about our healthcare system, that it was, you know, it was never a consumer experience. We always had this, you know, challenges galore with interoperability and so forth. The idea of having all your medical records that you own, that you control, that you give permission, that is something that obviously we're not there yet, but it's been very, very top of mind and prominent.
Indeed. We're running out of, as usual, ending up with very little time. Alexander has also mentioned too, and he's quite right, that we should look at IHE and HL7, which I know you, Raj, have been very involved with. And so when you comment, Raj, if we just it's also a wrap up, a comment from you as well, because we only have about 3 minutes left. Please, over to you.
Brian, I used a term, we used to talk about technical interoperability. I said we need human interoperability. Listening from what he said, I will say political interoperability is needed now. Now, having said that on a lighter note, but there is an international standard harmonization task force. I think, Brian, as ECHA and Global Health Connector, we need to interact with them. I also at one time addressed a joint meeting of the World Trade Organization and WHO. I think we need to get to talk to them because it is cross-border and these organizations are very important. So the International Standards Harmonization Task Force and World Trade Organization, I think as all of us were talking, we don't meet for the sake of meeting and doing a webinar. We meet for saying what one thing we can change, even if it is in a small way. And I think under your leadership and with great such people on the frame, I think we will bring that change. I'm quite hopeful. Thank you.
Right, thank you. And if you just want to wrap up, you've got 60 seconds to do your usual. Please. I
started it by saying I'm honored to be in this conversation with you and Raj and Amit and Bleden. It's been an incredible source of inspiration for me personally and for our community at large. So again, thank you for this.
And I look forward to seeing you soon in Washington.
I look forward to it.
Indeed. Bleden, I'm going to hand back to you in a second. Do you have any quick comment? Because I'm very keen to make sure that there is follow-up from DHS within the Global Health Connector as well. So maybe you could do the two things.
So without doubt, I will be in touch with Anne, Raj and Amit and following up on some of the things. I've made some extensive notes. So ladies and gentlemen, I will be in touch.
That's the lawyer's training. Because every time we talked about it, he's the only one that takes notes. And then he says, you did say the following. And I go, did I? But anyway, so just to wrap up and say to all the audience, and thank you very much indeed. I hope you've enjoyed this Global Connector session. There will be more, and we've got lots of plans for the future. So I would like to hand you back now to Bleden to pick up on the rest of the event. Thank you, Anne. Thank you.
Raj. Thank you.
Thank you.
Thank you very much.
Pleasure.